Lisfranc. So the red line is the Lisfranc ligament. The yellow circle is the Lisfranc joint. And the green rectangle is the Lisfranc joint complex. The bases of metatarsals 2 to 3, M2 to 5, M2 to M5 are very well connected to one another with dorsal, interosseous, and plantar ligaments, which are known as intermetatarsal ligaments. There is no connection between first and the second metatarsal, M1, M2, but there is a ligament between M2 and the medial cuneiform known as the Lisfranc ligament. Panjwabi et al. And various other studies have shown anatomical variations in the Lisfranc ligament. So the most accepted concept is the midfoot column concept. There's one medial column, there's one middle column, and there is one lateral column. Middle column, which is of our interest, has just 0.6 mm of movement in the sagittal plane, highlighting its importance in the anatomical reduction of the joint whenever we are going for a surgery. So, in etiology and classification, although rare in presentation, Lisfranc injuries, in the perspective of total amount of trauma cases, they are most commonly caused by motor vehicle accidents, 43%, followed by fall from heights, crush injuries, and sport injuries. They can be divided into high energy trauma, predictably with poor prognosis, and low energy trauma, sports injuries with considerably better outcome. The most commonly used classification system was developed by Meyerson in 1986 and built on the work of previous systems, including that of Quenu and Hardcastle. Although it is not prognostic, but high intra and inter-observer reliability was noticed. There is another classification, Nonley and Vertelo, which is used for athletic Lisfranc sprains, but it is not used most of the time due to the availability of MRI imaging now these days. Currently, there are no universal classifications to guide prognosis and treatment in any Lisfranc injury. It can tell you about the stage, the structure is intact, but it will not guide the prognosis. The prognosis is determined by the grade of injury and the amount of energy transferred. So there is one direct injury and indirect injury, which is comprises the mechanism of injury. The direct injury is a straight impact on the midfoot, and the indirect injury is where axial force passes through the second metatarsal. 97% times there is dorsal displacement. So evaluation and imaging. Acute midfoot pain following trauma should immediately raise suspicions for Lisfranc injury. Patient may or may not be able to bear weight. Pain out of proportion is also a pointer. Midfoot swelling and plantar chymosis are often considered pathognomic. Pain out of proportion might also represent the compartment syndrome or in first metatarsal space. In our country, neglected trauma usually presents in outpatient setting with a very low deformity, which is the loss of medial facet, tarsometatarsal joint, and not navicular joint, which is the case with flat foot. Weight-bearing radiographs are essential, AP, lateral, and oblique views. Flex sign is a pathognomic avulsion sign of Lisfranc ligament. CT and MRI required for bony Lisfranc and ligamentous Lisfranc injuries, respectively. So the management issues, what is the injury, whether it is stable, unstable, how to move ahead with it, whether should we go conservative or go operative. And if we are going operative, what should be the timing and the method of fixation? What are the outcomes following the surgery using different methods of fixation? Is anatomical reduction essential or relative stabilization can be achieved and let it go, as in extra-articular fractures? And the most recent controversy, primary arthrodesis or fixation. So the article mentioned here is published in 2017 by Lau et al. In Journal of Orthopaedic Trauma. It's a level 3 evidence study, but it shows that in all the three different modes of hardware used, the anatomical reduction was important, but in the long term, they didn't make any difference whether you used a plate or a screw or a combination of both. So the various methods available to us, conservative, stable, or extra articular injuries can be left on a conservative mode of management. Hardware options which are available to us are K-wires, transarticular screws, dorsal bridging plates, tightrope, or the endo button which we use in ACJ joint dislocations. K-wires are smooth, hence there is no rigid stability, loosening, and currently there is no evidence for use now. Open injuries, compartment syndrome demanding temporary stabilization may use K-wires, but they need to be changed to definitive fixation as soon as possible. Tightropes shown to be biomechanically similar as transarticular screws, but they fail under higher loads. Cadaveric studies show that intramedullary transarticular screws show statistically significant lesser plantar diastasis, which is opening up, than plates in higher cycles of load. But the issue with screws is damage to cartilage, which might be a problem later down the road. Screw breakage while removal is also common. Dorsal bridge plating has better radiological and functional scores with immediate weight bearing post-operatively, as mentioned in the JBJS 2019 article. So the main controversy is open reduction internal fixation versus primary arthrodesis. So on all the studies done before 2016, the sample size was kept low. So in 2016, there came a level 1 evidence article, a meta-analysis of 3 studies in which are mentioned in the picture here, which showed that there was no difference between open reduction internal fixation versus primary arthrodesis. A 2023 study in JOT also, it's a level 3 study, also showed the same thing. But in 2021, by NAC Van den Boom and other workers, they published a study with 392 patients, a 20 study meta-analysis, and it was a level 1 evidence which showed that primary arthrodesis is better as compared to open reduction internal fixation. I also asked an artificial intelligence researcher, and it also found the same thing. So the take home message is, in this is a protocol for decision making, that we need to be keep a very high index of suspicion. And arthrodesis, primary arthrodesis, is something which is not to be kept out of mind. It is very feasible, it is very economical, cost saving, and there is no need of a resurgery required. But again, as I said, there is a high chance of missing out on these injuries. So a very high index of suspicion is required whenever you encounter a midfoot injury. These are my references. Thank you.
Okay. So that was nice. You finished in time. Dhar sir, you have any questions to begin with?
Yeah, some comments and some questions. One, regarding your although you presented very smoothly and quite in detail, but regarding your presentation, I think in the last so many sessions we have highlighted that you don't need to fill up your all the slides with all the material. We are not here to get a full theory question answer that you need to mention everything. But this is a presentation where you highlight the main features, and so your presentation was quite smooth, but your slides were very heavy and probably very difficult to read. So first few slides are very attention seekers, so you should know how to present first few slides. So regarding your the methodology and all that, you have presented detailed analysis, but I have probably missed that. What about the lateral column, medial column, to understand, and what is the timing of the surgery? When do you actually how much do you sort of watchfully neglect or watchfully do early temporary fixations? I could not, probably maybe I have missed that.
Sir, so in temporary fixation, like if there is swelling present, so we will wait for 7 days for the wrinkle sign to appear. If the wrinkling is there, then we can go for definitive fixation. And now for that 7 days, if we want, we can put a, let's say, fixator or a K-wire and put it on, or just not touch it at all. Just wait for 7 days, let the wrinkles appear. Now for the
But there is a school that you should do it as early as possible, the reduction, because there is compartment syndrome. Then later there might be foot ischemia and all that. So I wanted some references on that. I don't know whether you have studied
No,
that.
sir, I didn't present regarding that.
Something like temporary fixation, whether we should do temporary and then definitive fixation.
I mentioned it in one of my slides, but yeah, but I didn't present a source for it. So yes, we do use K-wires, which is the most common that we are trained to do. We use K-wires for temporary fixation. And in many cases, I have seen people just keep a K-wire through the second metatarsal and put a cast, and the patient keeps on walking, and there is not a very poor outcome regarding these. So yeah, K-wires in our part of the world are definitely advised, but in literature, they have fallen out of favor. And so
anything regarding early implant removal or anything you should.
So in
you're doing a fixation, not orthodesis.
Sir, definitive. Now the literature has shifted for arthrodesis, not for implant retention, because
that you presented in quite detail.
Implant. The problem with implant retention is while removing screws, there is most of the time the breakage is there, and it damages the cartilage. So I didn't speak it, but there was a point in my article in my presentation in a 1997 study, which showed that usually primary osteoarthritis doesn't develop in the Lisfranc joint, but it happens when there is disruption due to trauma. So that is the problem with this. Now, if we put a arthrodesis transmetatarsal or intermetatarsal screw, the drilling will cause damage to the cartilage. So that's why the dorsal bridging plate, Lisfranc plates came into existence in order to spare and put a kind of a spanning internal fixator to keep the arthrodesis or the ORIF intact, so that the ligament heal. That is the main point of ORIF, to heal the ligaments and provide a structure for passing of the forces in order during the gait cycle.
Okay, thank you. Over to you, Ashok.
Yes. So, Anushrav, how will you differentiate between treatment of an athlete as well as non-athlete
Sir, athletes and non-athletes.
for Lisfranc injuries? Is
Sir,
there any difference that you will have
sir,
in decision making or surgery?
if it's a bony, the differentiation comes between a bony Lisfranc and the ligamentous Lisfranc. Now, if there is a bony injury there and there is more than a 2 mm step off and it's unstable on stress views, because most of the time these are neglected injuries that present to us. So if there is I would ideally get
acute injury in an athlete.
Acute injury in an athlete, and if there is no bony injury there, the literature suggests arthrodesis, but I would rather wait and watch, because
so you will let it go as a, say, observed neglect.
Yes, observed neglect, because advising surgery for Lisfranc for a athlete, I might do much more damage in operating him rather than, if the deformity or the pain persists, which is usually the case. Most of the time, they present to us after 3 or 4 months when it hasn't healed due to the local interventions. So
he's an athlete. He needs dynamic stability. If you fuse the joint, it will become an issue, right?
yes, sir. That is why I would rather wait. And but yeah, that before 2021, there was
based on what you have seen in literature review, if you can give me an outline. So nowhere in your literature review it is mentioned that we wait and watch, but you're still going with wait and watch.
No, sir. There was a conservative option there.
But it is a high conservative as indication, but it is like a high demand athlete with an acute injury.
Then, sir, I would go for if he's okay with a resurgery, then I will go with ORIF. Well, that's what I have done. I haven't done an arthrodesis in my training, so I would go with the ORIF.
At your level, you can also take an opinion of an foot and ankle surgery.
Yes, sir.
Sure. Okay.
So I will ask one simple question only. You in at least 2-3 places you have said that there is a high chance that you will miss this injury. Is there any special view of the X-ray compared? See, normally whenever there is a foot injury, we will just advise a foot AP and oblique X-ray in a lying down position. So is there, or sitting position, is there any special X-ray which you will advise to diagnose a Lisfranc injury which is not that obvious?
Sir, weight bearing and bilateral. We will see the other side foot also in order to see the distance between the first and second metatarsal. There is one school of thought which says that 3, 4th, and 5th the base of the 5th metatarsal and the cuboid distance should be less than 5 millimeter. But that is a very random, that is not a very practiced, but I would rather advise a weight bearing and a bilateral.
Actually, weight bearing is the right answer. Have you ever taken a weight bearing X-ray? Most of the X-ray technicians will not know. So you will have to actually go there and supervise the weight bearing X-ray yourself. So that is the important take home point from this.
Yes, sir.
For first 7 years of practice, I did not know how to take a weight bearing X-ray unless I met Dr. Rajiv Shah. So you should all learn how to take weight bearing X-rays of foot and ankle. Weight bearing and gravity stress views. These are the 2 things which you should take to miss out non-obvious injuries. Okay, thank you, Anushrav. I think that's all from our side. Now over to Dr. Jeshwanth. Can you just share your screen and start the presentation?
Is my screen visible, sir?
Yes.
Yeah, I'm a fellow in orthoplasty in Ganga Hospital, sir. Today's my presentation is use of tranexamic acid in TK, a review of its effectiveness. The question is, I had a question, why this topic and why the effectiveness? I have 5 reasons. Number one, there is a rise in literature. From 1995, the first published evidence for tranexamic acids used in arthroplasty has been established. From then, there is a steep rise till today in the publication literature, and in every conferences, there is a panel discussion over tranexamic acid use. What an arthroplasty surgeon needs in terms of tranexamic acid: reduction in blood loss, reduction in complication, and safety of the patient. Why safety of the patient is important in arthroplasty situation and arthroplasty OPD? Because the patient walks in, and we want the patient to walk out in a safe condition. What is the implication of tranexamic acid? Most of the arthroplasty patients or knee patients are elderly and with high comorbidities. They have a high chance of acute postoperative anemia. In turn, they will require transfusion, and they will have a chance of developing a related complications. What is the day-to-day challenge? The fourth one is the day-to-day challenge. A patient like this walks into my OPD and asks me that I want a single-stage bilateral TKA. And you can see the severe varus with the bone defects present. And this patient will need an extensive surgery, medial reduction, osteotomy, stem augmentation, and blood loss is definitely there for a single knee. And I have to do a bilateral knee at a single stage. Then the use of tranexamic acid is a tool for this patient. And today is the day of ERAS and fast track surgery, and all the corporate hospitals throughout India provide the services. That is a single day discharge or second day discharge. The tranexamic acid is also an invaluable innovation in this situation. The aim of this review to assess the efficacy of tranexamic acid in patients undergoing TKA. The methodology, I have chosen PubMed and Ovid. I have taken a level 1 evidence from the past 10 years, that is RCTs, systematic review, and meta-analysis. I have included 5 RCTs in this review. This is a meta-analysis published in 2015 showing the efficacy of tranexamic acid. It clearly shows, you can see the porous plot, that tranexamic acid is efficacious in preventing blood loss and total blood loss and transfusion rate. Then what is the aim of this review? The aim of my objective of this review is to find which route and what dose is most effective and safe. What are the routes available? One is IV and topical application. Third is nowadays Chinese publications present with retrograde transfusion through the drain of tranexamic acid, and recently oral applications or oral intake versus IV tranexamic acid is also published in the recent literature. Combination of routes. The recent literature, like in India and in abroad also, they have searched, in Western literature has come to the conclusion that combined routes of administration of TKA will provide safe and effective blood transfusion strategies. Dosing and timing, there are single dose and multiple doses. Single doses, the standardized Western protocol is 1 gram intravenous tranexamic acid or 3 grams of topical application with dilution with the normal saline. In multiple doses, they give 1 gram intravenous tranexamic acid in upwards of 2 hours or 6 hours apart duration. The timings are before, when you're using an IV, it is given before tourniquet. When you're giving a topical application, it is given before the tourniquet deflation. And onset of action in tranexamic acid in IV is 15 to 20 minutes. This is an article published by Matthew Abdel from HSS. This is published in 2018 with the power of the study is 85. This is among the 5 RCTs. This is the RCT with the highest power of study, which included 640 patients. In this, they clearly stated that intravenous administration of tranexamic acid when compared to topical reduces blood loss and blood transfusion rate, but they observed an increased rate of thrombotic events in intravenous use of tranexamic acid when compared to topical application. Before 2015, all the published literature says that there is no incidence of DVT or any thrombotic events. But after 2015, there are evidences and published reports of thrombotic events with the use of tranexamic acid. The second article, this is also an article published by HSS by consecutive in the year of 2019. In this study, they have compared both IV and topical application. But the thing is, the outcome they have seen the wound site aspirate and the blood levels of plasmin, antiplasmin level and prothrombin factors, which are direct measures of coagulation factor. Indirect measures of the coagulation. In this, they say that the decrease the calculated blood loss and length of the hospital stay, and they advised giving an IV tranexamic acid over topical application, which is, they say it is more effective. But in terms of safety, both the studies have said the safetiness cannot be measured with the same power of the study because it needs a very larger population and all the patients should not have any comorbidities or any predisposing factors. There's a published meta-analysis, that is safety and efficacy, published in Journal of Clinical Pharmacy and Therapeutics, has advised that multi-route, that is intravenous and both intra-articular administration combined, reduces the blood loss and transfusion rate. Then in 2023, what is happening today is they are using the tranexamic acid even in patients with coagulopathy and check whether and it has been checked for its efficacy. It is proven that even its efficacy is not changed even in coagulopathic patients. That is, it reported estimated blood loss is same as when compared to the non-coagulopathic patients. The American Association of Hip and Knee Surgeons also advises combination of routes and multiple doses, and they say it does not increase the risk of VT at all. The conclusion: IV tranexamic acid is more effective. Intravenous tranexamic acid attains higher wound concentration when you use the intravenous when compared to topical application. Combined administration is effective in reducing total blood loss. These are the references. Thank you, sir.
Thank you, Dr. Jeshwanth. You finished with more than a minute remaining on the clock.
Yes, sir.
So, Dhar, sir, you have any questions to go?
Yeah, I will ask first.
Yeah.
So I wanted to know that if the patient is diabetic
Yes, sir.
and has a higher chance of developing peripheral vascular disease, will you still give tranexamic acid? Is there any literature about that? The use of tranexamic acid in diabetics and TKRs?
Sir, I didn't find out the literature, sir, but in diabetic, it can be given, sir, because unless until the patient has a proven history of a DVT, we can still, because
not DVT, I'm talking about PVD, that is peripheral vascular disease.
arterial thrombosis, it is to be, it can be given, sir, because it doesn't promote it doesn't promote thrombogenic activity, sir.
Okay, got it. One more question from my side. What is the preference in your institute to give topical or IV, and to give one shot or multiple shots?
Sir, in our institute, this is IV 1 shot 20 minutes before the tourniquet application, sir.
That's it. And after that, it's not repeated post-operative at all.
It is not repeated post-operatively, sir.
Okay, thank you. Sir, you can take over.
Okay. Thank you, Dr. Jeshwanth. It was a very nice presentation and good slide making. My only question is, although you have presented in quite detail, that in the local application, I don't know whether you are not doing it. You said you are doing only IV. So in the from the literature, in the local application, is there any particular method? Like we just, even I do it, in my team does it like we just pour it over it. We mix it, or sometimes we just rub it around everywhere. So is there any standardized method for that?
The protocol which is followed in the hospital for special surgery is described by Matthew Abdel. He has said that after the cementation, but before the tourniquet deflation, they will irrigate with 3 grams of tranexamic acid with 45 ml of saline. They will irrigate it, and they only suction the excess amount of the fluid, not till the capsule, sir. They will allow, and once the hemostasis is achieved, then they start the closure.
Oh, so that is how much time? Is there any standard time that you wait for?
Time they have not provided, sir. They said after the cementation, immediately after the cementation, until the tourniquet deflation.
Okay. Okay, that's all, Ashok.
Okay. I think in view of timing, we just move on to the next candidate.
Yes, sir. Thank you. Absolutely, sir.
Yeah. So I'll invite Dr. Harsh to share his screen and go ahead with the presentation.
Yes, sir. Good evening, everyone. I am Dr. Harsh Kotecha, currently spine fellow at Sion Hospital. Given a topic of transforaminal lumbar interbody fusion regarding indications, techniques, and complications. The learning objectives for today will be: what is the history behind TLIF, why is it better, the indications, and outlining the important aspects pertaining to the techniques and recognizing the potential complications. The history of interbody fusion is there since past 3 to 4 decades, where first time interbody fusion was started in 1946, which was followed by Harms and Rollinger, who introduced the unilateral posterior transforaminal access to the anterior column in 1982, and in 2006, Holy was the first person to start MIS TLIF. Why TLIF? The extent of neural structure retraction, the potential injury to the nerve root, dural tears, epidural fibrosis, in comparison to posterolateral interbody fusion, was very less in TLIF. Preservation of ligaments, 360-degree fusion with single incision, the reduction in blood loss and the muscle injury, especially in endoscopic TLIF and MIS TLIF. And TLIF is superior to anterior lumbar and OLIF in terms of approach-related morbidity and learning curve. Difference between posterolateral and transforaminal interbody fusion. In long-term outcome, the fusion rates are almost comparable, but the amount of lordosis that can be achieved is far better in transforaminal lumbar interbody fusion as compared to a posterolateral interbody fusion. Indications of transforaminal lumbar interbody fusion: degenerative disc disease, low-grade spondylolisthesis, recurrent disc herniation with foraminal stenosis, degenerative scoliosis, pseudoarthrosis. Pertaining to degenerative disc disease, there was a study which gave us, which used criteria given by Patira and Memora in terms of facet degeneration and disc degeneration radiographically, where with severe end-plate sclerosis, advanced osteoarthritis, and severe disc collapse, posterolateral interbody fusion was preferred over transforaminal lumbar interbody fusion. Recently, with advent of robotics and 3D navigation, indications of transforaminal lumbar interbody fusion, especially MIS in spondyloptosis, plays a significant role. There are basically 3 techniques for transforaminal lumbar interbody fusion: open, endoscopic, and minimally invasive. The open TLIF follows a standard posterior approach where unilateral facetectomy is done and this space is addressed via the Cambian's triangle. The minimally invasive spine technique uses the Wildsey approach, and expandable tubular retractor is used to access the posterior elements. Skin incisions are 2.5 centimeter lateral to the midline. We develop a plane between multifidus and longismus, and self-retaining retractors are placed. The endoscopic TLIF is mainly performed with the help of the unilateral biportal endoscopic systems, where ipsilateral laminectomy and facetectomy is done. Discectomy and end-plate preparation are performed with the aid of endoscope. Autograft and interbody cage are placed through the working portal. And finally, percutaneous pedicle screws are inserted bilaterally. Endoscopic TLIF is superior to MIS TLIF, is superior to open TLIF in terms of blood loss, paraspinal muscle injury, hospital stay, rehabilitation, acceptance of the procedure by patient, and the morbidity present in the patients. But endoscopic TLIF is equivalent to MIS TLIF, which is equivalent to open TLIF in terms of union rate and clinical outcome in long run. And there are enough level 1 evidence given by multiple studies proving these things. The drawbacks of minimally invasive spine and endoscopic TLIF: there is an increased requirement of intraoperative fluoroscopy, special bayoneted instruments, the learning curve associated with it, and managing of the complication, especially the CSF leaks. Variations in TLIF are done by various surgeons to improve the clinical outcome in terms of bilateral facetectomies in place of unilateral facetectomy, which has proved not useful and increasing the risk of neural injury. What is the ideal placement of interbody device? It is found to be anterior third because it increases the construct stiffness, decreases the rod strain, avoids subsidence, and superior lordosis correction. Usage of expandable cages versus static cages in TLIF: there is no significant evidence in terms of better segmental lordosis, pelvic parameters, or cage subsidence. Unilateral pedicle screw fixation in fusion versus bilateral fixation in fusion in TLIF: it has been concluded that unilateral pedicle screw fixation in fusion is superior over bilateral, but is associated with an increased cage migration risk. The usage of titanium coated PEEK cages versus uncoated PEEK cages has shown that there is no difference associated in terms of cage subsidence irrespective of these material. The complications associated with a transforaminal lumbar interbody fusion irrespective of the approach that we take are divided into an early perioperative and a late perioperative category. Early perioperative general associated with the physical condition of patient, and surgical where we mainly see incidental durotomy, screw malposition and cage slippage. Late perioperatively we see a biologic failure in terms of pseudoarthrosis, a biomechanical failure in terms of implant loosening, errors in the surgical strategies, especially MIS and endoscopic, leading to cage subsidence, and technical errors leading to an adjacent segment disease. The amount of pseudoarthrosis and the adjacent segment disease can be assessed in follow-up using the Bridewell Interbody Fusion Grading Score and the University of California at Los Angeles grading scale for adjacent segment degeneration, where they see the disc space narrowing, the osteophytes, and the end plate sclerosis. The cage subsidence rates have been decreased by usage of a 3D printed porous interbody cage with stress optimized body lattice and microporous end plates. And this has given a significant improvement in the early fusion. Conclusion: posterior interbody fusion is the workhorse of surgical management of stenosis, instability, and deformity. Critical steps in a TLIF will be establishment of a prone position that maximizes the lordosis with gravity, protection of the vertebral end plates while disc space preparation, appropriate cage size and positioning. We have to change the approach if lordosis is the aim of surgery, and there is enough evidence to prove that a well-performed PLIF or TLIF, irrespective of the approach, gives equal results in terms of bony union and clinical outcome on long term. Thank you, sir.
Thank you, Dr. Harsh. You two completed with 1 minute left on the clock. So, Dhar, sir, you have any questions to begin with?
Yeah. Once again, Harsh, very detailed presentation, but again structured very haphazardly partly. Although you presented so much material. And besides, our topic was TLIF, not minimally invasive TLIF. So you focused a lot on minimally invasive. So that is what generally happens. In your effort to impress the audience, you try to push everything there in that 8 minutes or 9 minutes, which is very difficult. No audience will get impressed with that. So you should take one single point and then focus on that and try. Even if you carry one single message in your lecture, that is good enough. You don't have to. It's not a teaching students. It is basically you are presenting somebody who is already knowledgeable. But anyway, a very detailed presentation. Thanks for that. I wanted to know, did you study? See, when we started spine surgery, we moved from PLIF, posterolateral interbody fusion, where we would even put both sides ilicrus grafts and then put pedicle screws and all that. Then we moved to big cages. Then we moved to mesh cages. Then we finally moved to bean cages. Now we are again oblique cages. Now we are even like OLIF and all that is happening. So in your literature, the union rates, I think you presented it somewhere. So now we are again saying that bean cages, the curved cages are much more better than oblique cages. What about the latest literature? Could you study that?
Yes, sir. I had studied an article which said that irrespective of the type of cage we use, the union rate doesn't matter. They had compared bean cages with the oblique cages and with other different types of cages were included in the study, including the material of the cage also. Where this one PEEK cages, titanium coated PEEK cages. But at the end, union rates were not significantly different from each other. And it was a meta-analysis of a multi-centric study.
And what about bone density and DEXA scans? Is that really a matter when you do these procedures?
Osteoporosis is a relative contraindications for transforaminal lumbar interbody fusion. They prefer posterolateral fusion in that, sir.
Okay. And you said in your one reference, you said that unilateral is as good or maybe better also. Could you give us more details on that? Because
Yes,
that
sir.
is, in fact, surprising to me. What is
Recent,
the reason that it is better? Except only thing I can think of that you have a large fusion bed posterolaterally. But is that the case? Did you study that reference
yes,
in detail?
there was a recent 2023 meta-analysis where they did they studied 15 to 20 RCTs where unilateral pedicle screw fixation was done with fusion, transforaminal fusion, and they compared it with the bilateral pedicle screw fixation. So it was less operative time, less blood loss. In terms of that, it was superior to bilateral pedicle screw fixation. But they had only one criteria where there was an increased cage backout or misplacement of cage C.
No, but what is the entry of the cage? It is on the same side as screw side or
The same
opposite
side
side?
as screw side.
Okay. So the other side is not.
It is not touched only.
Okay. Thank you.
Okay. Thanks, Dr. Harsh. Neeraj, you have any questions? Okay, I think Neeraj is. So, Dr. Harsh, like sir asked in the beginning, you focus more on minimally invasive. So, does it the minimally invasive offer some unique advantage except the less muscle injury over the conventional one?
Sir, all the studies that I went through, they all concluded that if we the benefits of minimally invasive and endoscopic TLIF are all on short-term basis or immediate relief to the patient.
Mhm.
But on long-term clinical outcome and the back pain, pertaining the back pain where we do TLIF, there is no clinical difference. Matlab, the union rate and the clinical outcome are similar in any procedure until and unless it is well done by a qualified surgeon.
Okay, fair enough. Okay, let's move. Thanks, Dr. Harsh. We'll move on to the last candidate today, Dr. Pratik Dhabalia. Please share your screen and we'll go ahead with your presentation. Dr. Pratik.
Yes, sir. Is my screen visible, sir?
Yes.
Good evening, sir. I am Dr. Pratik Dhabalia. I'll be presenting on proximal tibia fractures, current decision-making paradigms. These proximal tibia fractures are a diverse group of fractures with wide spectrum of severity. And they range from a simple injury to complex fracture patterns that may be challenging. The fracture pattern dictates the treatment plan and risk of complications and outcome of the patient. And the fracture pattern is dependent on the magnitude, type, and direction of the forces which injure the knee. These fractures are quite common, 1 to 5% of all fractures. They make up to 10 per 1 lakh inhabitants, and they are most commonly in 4th to 6th decade. In men, they are more in young men, and in women, they are more in elderly age. Mechanism of injury, they may be a high energy trauma or a low energy trauma. High energy trauma is majority in male patients, which lead to comminuted complex fracture patterns with or without soft tissue injuries or neurovascular injuries. Low energy trauma because majorly of the trivial falls in elderly females more commonly, which may lead to a unilateral depression fracture types more common on the lateral side. The direction of the force may be medially directed, valgus force, which causes classical bumper fractures, or it may be a multidirectional combination of medially directed, laterally directed, or axial force through the femur, which may cause various fracture patterns. So coming to managing the proximal tibial fractures, the principles and techniques have been evolved dramatically over the last 50 years. Previously, we were totally dependent on non-operative management, including cast, bracing, skeletal tractions, close reductions. And the outcome was quite good with the patients, even with some amount of articular step in the left in the tibial articular surface. As with the time, the operative interventions evolved, the internal fixation matters improved, and they gave the advantage of reducing the articular surface, aligning the limb properly, and mobilizing early, and they were less cumbersome. These are few old papers which made the shift from close reduction and conservative methods to the internal fixation methods. Although these papers are all of historical interest, they all direct to the same point that articular surface of proximal tibia is tolerant to the modus of deformities and treatment will result in favorable outcomes. Still, the criteria for which fractures needed to be surgically reduced are still a controversy, and guidelines that how much amount of articular step is acceptable is still a controversy. Current concepts for any proximal tibia fracture, we have to assess the fracture pattern, we have to plan the surgical approach. Obviously, we have to look at the skin condition, soft tissue status, associated ligamentous injuries of the knee, and management of complications and general condition of the patient. So currently, there's a shift from a fracture dictated operative approach rather than the classical anterolateral and posteromedian approaches. Aim of this, because different fracture patterns require different patient positioning, surgical approaches and treatment strategies, it is important to distinguish significantly injuries from each other. Aim of the surgery still remains the same, that is reconstruction of the joint surface as accurately as possible, reconstruction of the knee axis and a highly stable tibial plateau, and early mobilization of the knee. Also, the retention of the meniscus. So when a proximal tibia patient presents in emergency room, we have to assess the limb condition. We get the imaging, 3D CT and MRI. If there are significant soft tissue injuries or a lot of swelling, blisters, ecchymosis, neurovascular deficit, we first scan, and then plan with external fixator. Now we have monolateral carbon fiber fixation systems available, which are radiolucent and help in give us time for managing and planning the proximal tibia. And then we can move on to definitive fixations. Obviously, if we see a limb like that, we have to wait for some time. Classification system, we have shifted. There are a lot of classification system, but we are using majorly Schatzker and the AO classification system commonly and widely. They divide the proximal tibia based on medial lateral bicondylar and metaphyseal diphyseal dissociation. However, they have shortcomings that they do not use the additional information provided by the CT scan and the MRI, and they provide a 2D image of the X-ray of the fracture, and they do not consider the accident mechanisms and concomitant injuries. So this is a X-ray of a proximal tibia fracture. These are both types as Schatzker 6. One is very minimally displaced, one is severely comminuted. So that is the shortcoming. So they have evolved new classification system by Luo et al. And Cross et al. Luo et al. Divided the proximal tibia plateau into 3 columns: medial column, posterior column, and lateral column. And they gave a special focus on the posterior lateral corner, which is surrounded posterior laterally by the fibular head, which is difficult to reach surgically. And they have also given a criteria suggesting that anterolateral approach can be used to reach the posterior lateral corner. Krause et al. Divided the proximal tibia into 10 segments with 4 quadrants having 2 segments each and 2 segments in the center, anterior center and posterior center. And accordingly, you have to decide the approach, patient positioning, and surgical strategy. The ideal classification is still yet to be found. There's a lot of inter-observer reliability. Now we have shifted from X-rays to a 3D recon and an MRI to assess the fracture pattern and anatomy and the ligamentous status of the knee. However, aim of surgery still remains the same. We have to reconstruct the joint, reconstruct the knee axis, and mobilize as early as possible. So conservative management is for minimally displaced fractures, minimally tibial edge fragments, small depressions of the lateral plateau. Contraindications with these are knee instability, displaced medial side, and patient with significant comorbidities. Conservative management can be done by casting, long knee brace, or a hinge knee brace. So this is an X-ray of a minimally displaced lateral plateau fracture without any depression, very minimally displaced. And this is 6 months follow-up of the same patient managed conservatively. This is a similar X-ray of an elderly patient who was medically unfit for the surgery with a lateral plateau fracture and depression, and she was managed with casting and bracing. And the X-ray below is a 3-year follow-up of the same lady with slight valgus deformity at the knee, but she's doing functionally well with the conservative management. Similarly, this is a medial rim eversion of the tibial fracture and may or may not be associated with a MCL eversion injury. It was also treated conservatively. So lateral plateau fractures, including Schatzker type 1, 2, and 3, and OTA B1, B2, B3, maybe the approach may be percutaneous fixation or a arthroscopic reduction and internal fixation or an open reduction and internal fixation. Managing the void in a depressed fracture can be done by either bone grafts or allografts or bone graft substitutes. But you should have to prevent subsidence. So this is a lateral plateau split fracture managed. Firstly, we were using percutaneous screws. Then we shifted to screws with a washer, a single screw or a double screw, which may be divergent, which may be parallel. Then we have shifted to raft screw with multiple raft screw that give a bridge to the proximal tibia surface and prevent subsidence. Then we have shifted to the screws can be also used through the plate, which are raft plates, by anterolateral approach for the lateral plateau. This is another X-ray of same raft plate. Recently, in 2012, there was a new technique. A jail screw was used, which gave extra support to the depressed fragment of the tibial plateau. This is the X-ray of the same technique. Now, since last 1 decade, we have shifted to arthroscopic reduction of the internal of the tibial plateau because we have to reduce the chances of secondary osteoarthritis. It gives better visualization of joint, accurate reduction, quicker recovery, and associated meniscal injury can be treated same. There's a lot of literature regarding the compartment syndrome which develops due to the fluid extravasation in the joint. This is just an X-ray of the arthroscopic reduction. This is an extra port which is extra port which is used to visualize the joint, and there's a K wire or a guide wire which is used through which the rimmer is passed. This is a arthroscopic view of the fracture. A bone tamp is inserted to elevate the depressed fracture, and this is the arthroscopic view after the fracture is reduced. These are the recent papers in 2023, 2015. Since last decade, we are using this, and they all support that the arthroscopic reduction is better functionally than the open reduction. However, the complications and the long-term patient outcomes remains the same. They also give a new term, fracturoscopy, for the same technique. For lateral tibial plateau fracture, we can also use the anterolateral approach where the anterolateral incision, which goes through the IT band and opens the joint via submeniscal approach. We put the stay sutures in the meniscus. We put a guide wire, then osteotome, then elevate the fracture and put a plate. This is the post-op X-ray after using a bone graft substitute for elevating the fracture line, and that is the arthrotomy closure. Some pitfalls are there that you may injure the anterior tibial artery. There may be soft tissue development, stripping, inadequate visualization, creating a large subchondral void. So you have to take care of all that. Isolated medial plateau fracture, that is Schatzker type 4, B1, B2, B3. You can approach either anteromedially or posterolaterally, posteromedially, or a direct posterior approach. However, we have shifted to a fracture-based approach. So we have to identify in 3D CT and then we have to follow the approach. These minimally medial displaced fractures can be nasty because they have coronal component as well, which may be missed. And they are very prone to varus collapse. Fixation this is a posterolateral approach. Fixation, you can apply plates in any method, either anti-glide plate by a posterolateral approach for the posterolateral fragment, or you can apply the plate in a buttress mode. This is an X-ray of dual plating done via one anterolateral approach and a posterolateral approach, and a posteromedial and an anterolateral approach. Same X-ray for posterolateral approach with a buttress plate and a lag screw. There are some complications which are very common with this approach is injury to saphenous nerve and vein, injury to popliteal sectors and popliteal fossa. So we have to try and protect them. Bicondylar fractures with metaphyseal diaphyseal dissociation. These are the most complex fracture patterns with wide range of severity. We can do either dual plating, locking plates, external fixator, or external fixator along with locking plates. Again, approach has to be decided according to the patient. There recently new approach came up, which is floating approach, in which patient lies supine and a reverse L-shaped incision is given for the posterior part of the tibia, And then patient is little tilted to the lateral side, and you can flex the knee, and then you can open up the knee in the anterolateral side. So you don't have to go and make the patient supine again for the same. These are few x-rays of the same. According to the fracture pattern, the approach is decided, and accordingly the fixation is done. Recently, we have shifted to these few newer modalities: arthroscopic reduction and internal fixation, osteosynthesis. Definitive treatment, primarily we are doing ring fixator for the proximal tibia fractures. There's balloon tibiaplasty, there's mypoplates, and there's primary knee osteoplasty for the proximal tibia fractures. These are few recent papers which states that primary ring fixators for proximal tibia fractures can be useful. They have advantages because they have minimally invasive. They allow early weight bearing. There's no additional devitalization of the bone, and the mechanical axis is well aligned. Previous studies, the old studies show that if you have a well aligned knee with mild articular step, the patient functionally does well in a long term outcome. However, some disadvantages are there. They give knee stiffness, they have pin tract infections. They do not assess the ligament injuries because we are primarily fixing the knee, and then they are assessed later on after the fixator is removed, and they are cumbersome for the patient. There's this new procedure called close reduction and internal fixation, which is done by balloon tibiaplasty. It is kind of kyphoplasty. We insert a cement cannula inside below the depressed part. We inflate the balloon. The balloon has multiple fenestration. It diverts the cement in multiple directions. It elevates the fragments, holds it there, and then you can put a K-wire or a osteotome, and then you can fix it. So advantages of this technique is still it is minimally invasive, percutaneous, multidirectional vector of elevation with large surface area of balloon. You may insert the cement in wrong direction if it is not traced properly, which can cause malreduction in articular step. The temp, which is very thin and sharp, may penetrate the bone because it is cancellous bone, and there may be extra vessation of the cement, and cement related complication of course can be there. MIPO locking plates or fixed angular plates with both reduction of articular.
Okay, Dr. Pratik, I'm going to stop you there.
Yes, sir.
Okay, so you have
I'm almost done, sir.
You have taken more than 14 minutes for an 8-minute presentation. That is one of the cardinal sins of presentation. Okay,
Right,
you have to time your presentation so that you finish well within time. Time
yes,
is most important not only for you, but also for the delegates and the people who are sharing you. So always remember for that.
yes,
Second point was you were way beyond the topic that was given to you. Your topic is proximal tibia fracture, current decision making. You started with demographic details, with etiology, all those things were unimportant. When you are given a topic, you focus on the topic, and you have been given a guideline on what to say. You have to given a guideline for review of literature on that particular topic. You can show one or two cases, but you are showing examples, surgical technique that is not in your purview of the topic.
yes.
Current decision-making paradigm is your topic. Okay?
Okay.
Dhar, sir, you have any questions for him?
No, basically, that's what Ashok already pointed out. Means the whole message, what should have come out. See, like when I treat the proximal tibial fractures, the dilemma with me is when to start, where to start, whether I should go posterolaterally or I should go posterior-medially. So one is assessment of the fracture. So what are the current techniques of whether we should do an MRI? Does MRI give any benefit? So you have not mentioned that. What we conventionally follow as 3D CT to assess the articular surface. That's what I said. Where to start? Whether I should go posterior medially first or I should go laterally first. So that is. Other thing is joint stability. That is a very important beginning, sort of. Whether you, how should you get the joint first stable? Then you think of articular surface cartilages. So whether it is a large posterior medial fragment or a large split fracture laterally. So unless you stabilize that, the whole thing doesn't fall in position. So we wanted literature or your assessment of that.
Yes.
So, although you have present very detailed, but it was not needed. So the topic when in a conference or wherever we give, it is specific. So good speakers, effective speakers are those who stick to that. Or as I told you, even if you are able to drive home one single point from that lecture, highlighted, and patient gets this delegates get one single message, that is good enough. Not that you don't want to teach them the whole
Yes, sir.
subject. Anyway, I think it was quite detailed. Thank you very much.
Yes.
Okay,
Okay,
Neeraj,
I have one
ready?
question.
Yeah.
Yes. So, this you have shown in your last few slides about arthroscopic assisted reduction.
Yes, sir.
Frankly speaking, though I've been practicing for 18 years, I have my partner who does a lot of arthroscopy. I am
Yes.
yet to do a arthroscopy assisted reduction in a proximal tibia. Means basically I have not needed it up till now. How many have you seen so far? And what does the literature say in that matter?
Sir, I have seen 3 so far only. But literature says that the long-term outcomes of arthroscopic assisted and open reduction are more or less same, but the short-term outcomes are better with the arthroscopic assisted. But of course, we are doing that for the articular steps to get it very accurately. So long-term secondary orthoarthritis can be delayed, but the long-term outcomes are more or less same.
As soon as the patient, you see the X-ray of a proximal tibia, as soon as you see the X-ray of the proximal tibia, which comes on WhatsApp sent by a junior resident, or if you see it, if you're in a private practice, then sent by your assistant, what is the first thing you will advise him? How do you immobilize him? And what is the first investigation would you like to advise him? And what is the first thing you'll be, first complication which you'll want to take care of?
Sir, will
3 questions.
Yes, sir.
Yeah, limb mobilization, first investigation, and immediate means investigation as soon as possible. And third is what is the complication that you would want to prevent?
Immobilize with the above knee slab, sir, and limb elevation. And the first thing we'll do is an X-ray and a 3D CT reconstruction. And we would like to avoid compartment syndrome, so we'll look for the signs of compartment syndrome.
Okay, very good. Instead of the above knee slab, I feel nowadays the long knee brace is a faster and easier way. Even before you reach the place, somebody can put the long knee brace.
Right, sir. Right.
Okay, at least immediately. Okay,
Yes, sir.
Thank you very much.
Thank you, sir.
Okay, so thank you everybody for your participation, and thank you Dhar sir and Neeraj for judging the session.
Is there any tips for more effective presentations, sir? Like slow, how to reduce the pace while presenting, sir?
Dhar sir, you have any tips?
Yeah, a few things I already told you in this lecture. One, understand the topic, what is needed in that. That is very important. In fact, there are much more effective speakers than I am. Even I try to learn every time. I know there are so many limitations I have in presentations. Although every time there's an effort that I should give a lot of information, but that is something which I have learned that it is of no use. We are talking to orthopedic surgeons. We are talking to people who are highly learned anyway. Today, there is an era of knowledge is floating everywhere. You have so many webinars. So nobody is one seminar, what you are presenting, nobody is going to get ऐसा voila that everything is coming up suddenly. ये आदमी अभी तक कहाँ था, इसने हमको इतना knowledge दिया. So even you know as much as I know as far as your topic is concerned. But point is how to drive home a single point or 2 points, stick to that. So like your presentation was definitely much better than as far as slides were concerned. They were much more organized, much more highlighted properly. So our eyes could go to that particular thing. While others had tried to present everything, means they wanted to present. I'm not trying to undermine others' marks or anything. I'm not trying to influence the other examiners today, but I am just trying to that it should be eye-catching. One is that it should be eye-catching. So don't load the slide heavily. So try to give very few information. You might add few words from your own means you speak about them. But then the point what you put on screen should be something which is of a very useful. There's no point putting every point on the screen. Second is like, as I told you, try to give one single message or 2 messages. Don't try to change the whole idea of उसका knowledge ही पूरा change कर देगा. That is not possible. Nobody on the earth can do that now. So stick to your plan and try to focus on a single point, like tibial condyle fractures. So maybe you could have said that what is the approach plan. So that would have been much more useful than every plating, whether you should do, or like you could say only articular comminution. These days we talk of rim stability and all that. So one single point which you can talk about, that would be more useful than, although the topic may be a little vague by the organizers, but you can still make it much more interesting.
Thank you,
I'm
sir.
sure
Thank
we'll
you.
have Ashok and Neeraj are organizing a session for all the members who participated in this. So we will have probably a webinar, which will be a combined webinar for everyone. It is of course voluntary. You may join, where I think Dr. Dhiren and many other speakers probably would. Before we go to finally to YROC, we'll have one session where there will be sort of tutorial of how to make effective lectures. I'm sure Ashok
Thank you.
is planning that. So we'll end up with that session.
Right.
Yes,
Thank you
thank
very much,
Okay, so
everyone.
I'll just give
Thank
one.
you, Ashok,
Yeah, I'll just
for
add one.
organizing
What?
this. Yeah.
Go ahead, Neeraj.
So I'll just add one or two more tips. This more than the presentation and the slides, especially when you're going to do it physically. So whenever somebody invites you to take a talk, always see to it that you should know what others are talking. Who are the others whom you're talking with? What is the target audience? It is when you're invited for a conference, don't see to it that you have communicated with the, supposing if you're part of one session where there are many people talking. So you may put classification, मालूम पड़ेगा सब लोगों ने classification डाला हुआ है अपने slides में. Then you'll say, हाँ, this person has put the classification, so I'll just skip the slide. That looks bad. Directly jump to a point. If you're given a 8-minute or a 10-minute talk, see to it that you rehearse it and you finish in 7.5 minutes if it's a 8-minute talk. And maybe just drive home, as Dr. Sir said, that drive home only one point. How is your body language? How you have dressed up for the presentation? Target audience. And when you are speaking, just imagine that you are in the audience. And what would you like to learn from that lecture if that lecture you would have wanted to listen 10 years back? So these small tips are very important besides how you present and how your slides are. And of course, I have shared Dr. Dhiren's video long back, but I will share it again today. It's a very small video. It will be best that if after tomorrow morning, by tonight, just have a look at that video, which was taken in YROC Global in the technology session. Okay.
Okay, sir.
I
Thank
think
you.
with that, I hand over to Dr. Ashok Shyam to close the session.
Yeah, I think I'll just thank all the speakers again and Dhar sir and Neeraj to join us. So thank you all very much. We'll see you at YROC. Thanks.
Thank
Yeah,
you.
thank you.
Thank
very
you.
much.
Good night.
Hello, sir.
Yeah, stop the streaming and recording.
Okay, sir. Okay.